Welcome everyone, and thank you for joining today's webinar on agentic medical billing and the underpayments no one's catching. If you're late to the party and watching the recording in your car or on a walk or maybe by the pool, it's summertime, welcome to you as well. Here's the number that explains why we're all here. Initial denial rates have nearly doubled over the last 5 years and now sit above 12%. However, 90% of those denials are completely preventable. And many of our clients and healthcare organizations know their denial rates. They even know the general reasons why they're getting denied, but they don't always know the root causes, or they don't have enough horsepower and manpower to fix it. So today, we'll show you where technology comes into play. And yes, we're talking agentic AI, another buzzword, but the important piece is it's with healthcare subject matter expertise at the center. So let's not talk theory. Let's go through the entire revenue cycle all the way from data ingestion, the status check, payment posting, AR follow-up, and finally, denials and appeals. The question is, can you do it all with automation? Where do you need people? So let's get into it. Let's introduce the panel. So starting with Susan. So Susan, if you don't mind, give a few words. Tell us a little bit about your background.
Hi, I'm Susan Caramelli. I am the Revenue Cycle Director for Cordio Healthcare. I have been in this industry for 30 years. I've seen started out when you just used a book to keep track of things, and now into computers, and now automation. And I love where the industry is going. So I'm excited for the future.
Super happy to have you, Susan. Now let's go into Rano. Rano, a little less interestingly, if you don't mind, but you can give a background yourself.
Yeah, absolutely. Way less interesting when we have Susan in the panel. But first of all, thanks for everyone who is joining us today. It's an exciting discussion that we are more than interested to talk about today. But myself, Rano Banerjee, I'm the Director of Healthcare Automation at Cordio. And once again, denials is a hot topic. It's a topic that is getting discussed every often. So I'm going to really figure out what the discussion heads out to, but I'm more than happy to share the stage alongside Susan, because there's a lot of people who would like to learn about at the end of today's session. So yeah, once again, thank you everyone for joining this session today, and we are very excited to see what this discussion gives us as insights.
Absolutely. So for anyone that is joining that wants to comment or ask a question, feel free to go after it. Now let's start with you, Susan. The question is around a healthy revenue cycle. So, I mean, what does a healthy revenue cycle actually look like? What numbers should a practice be hitting, and how do they know if they're behind?
Well, first I'm going to tell you what the whole revenue cycle is. The first component of it, and the one that isn't spoken about too often, is credentialing. You need to make sure that your individual providers and your groups are fully credentialed and enrolled with the payers, because if that's not done properly, then it stalls everything. You know, the payer doesn't recognize the individual provider and won't pay the claim. So the first step after that, eligibility needs to be checked before the patient sees the provider. You want to check for accurate and current coverage. Sometimes the patient can present a card and they did have that coverage, but it maybe has lapsed or it's an old card. So always check beforehand, because that can lead to some denials too. Okay. You need to make sure that the patient's demographics are accurately entered in the system. Transposed digits, again, can send the claim into oblivion. You have to make sure you get a correct social security number, date of birth, things like that. Make sure that's all accurate. Then upon charge entry, also make sure everything that is necessary from the individual payers is included in the claim. The patients will, you need to have the accurate CPT code. You need to have the accurate ICD-10 code to the highest specificity. Sometimes the vague ones won't, they'll work at some payers, but they won't work at most, or they'll trigger an audit. Then you need to use your claim scrubbing tools, the automation claim scrubbing tools. Those are wonderful. They help. You might think your claim is good, but those automated tools will catch things that you are unfamiliar with. You need to work the invalids and the rejects right away. As soon as you get them in your clearinghouse, when you catch them quick, it's easy to fix them and then get the claim right back out the door so you don't lose any days in the revenue cycle. When the payments come in, you have to ensure they're accurate and timely payment entry. You don't want to put the payment on a wrong date. You could do that, and then that date that you've put the payment on really is unpaid, but you're not pursuing it. And a date that is paid, you're pursuing, and there's no reason to pursue it. So it just saves a lot of time making sure everything is accurate. You need to be aware of co-pays, collect them at the time of the service, and then make sure you're balance billing timely for deductibles, co-insurances, and the like. And finally, I think this is important also. You need to stay aware of the industry standards and changes. Pay attention to those payer emails that they send you, that everybody kind of wants to just delete in their email, and the payer handouts. Read all of that stuff. That's really, that's how the payers tell you things that are going to be changing. And if you know it ahead of time, you're prepared.
Very well said. And there's actually a word that you mentioned, I believe it was 6 times, if I counted accurately. Actually, the word accurately, you talked
Probably.
about the importance of accuracy within eligibility, within demographics, within charge entry for the codes, within payment posting. Like, that is one of the key pieces. And the point is that a lot of this information, ever-changing pay rules, specifically what to do at each point, is in the brains of subject matter experts. Folks that, frankly, Susan, you manage. Your team is extremely experienced and knowledgeable about these things, but the gap is that in order to have all of that in place and handle extremely high volumes, the only way to do it is with that expertise and technology. As you mentioned, even in the claim scrubbing piece, no matter how intelligent you are, we're all human. And naturally, as intelligent that we will make errors, but we can have technology supporting us in a way, especially within things like AR follow-up, that I think you have to call or actually go to a portal, or claim scrubbing, where there's so much information there that it helps to have it. That's where technology can make a big difference. So with that being said, Ronald, now let's go to you. I mean, we talk about this term called agentic medical billing. You tell us, is it hype? Is it reality? Where is it genuinely working today? And where is it still further out than buzzwords in marketing suggest?
Yeah, absolutely. The question around hype, or is it really giving us results? That's a big question to answer. Now, one of the things that we have seen across the revenue cycle, maybe in the last decade or so, is that providers who have got some success by using AI or automation have chosen to use automation for tasks which are rules-bound and more repetitive in nature, where there is a deterministic right action which you can take without depending on a human always for his or her judgment. Let me put it this way. Tasks like insurance verification, payment posting, claim status checks, where you do have a deterministic right path to go on to, are tasks which can be automated with agentic AI. The reason is you have a valid rule set against which you can run these transactions. The transactions are way more standardized. But if you think about the need to have human billers or specialists, that will never go away. For example, like if you're trying to fight an appeal where you need some clinical judgment, or you are looking through the prescription which is messy and it's not structured, you would still need humans to kind of come up with their own sense of judgment and make sure that they can take up the action and take up the decision in those particular scenarios. Where agentic AI can help you is it can perhaps collate all the data for your specialist and give that data to your specialist so that the specialist that you have is actually more prone to take those decisions and is not spending time on hunting for that data. But once again, the task across the revenue cycle where you see the volume is pretty high and the task is more or less repetitive in nature, you can definitely be using Agentic AI. Also, let me put it in this way with an example. We work with a lot of providers who are almost running 500 to 1,000 eligibility checks per day. Now, it takes a certain amount of time for your front-end person to come in and run the eligibility check for 500 patients. What if you have an AI agent that can run the eligibility for all the patients who have an appointment on that particular day and give the results to your specialist at 7 o'clock in the morning, so that the moment the specialist comes in the clinic, he or she knows which are the data points that is absolutely accurate and which are the data points where I need to talk to the patient because I don't see the right coverage.
From this day forward, every time I hear the word accurate, I will always think of Susan. So Susan, just to go back to you, I think, Rana, you made very good points. And to your point, we all see the statistics around, okay, the top leading personnel are right on the front end. However, Susan, you've broken down how you deal with just a lot of messy data on the back end. And you spend a lot of time cleaning things up when data is accurate or you have to double check it. So getting it right on the front end makes everything. And obviously it helps with lower denial rates because you can't possibly get every little thing every single time. So if you don't mind, tell us a little more about claim scrubbing. So scrubbing is one of the areas where your team's experience really shows. And a lot of practices go wrong here before a claim ever even goes to the door. So tell us, Susan, what does an experienced biller catch that an inexperienced one may miss?
Right. There's plenty of things. The automatic scrubbing is wonderful. So, and it does catch things too, but sometimes just human error can be caught by the human who either has done it or is checking for her staff. So, like we talked about earlier, missed or outdated insurance verification, that's important. That's something that can be missed if you're inexperienced. Terminations, if new wordings are not added to the policy, if the copay hasn't been collected, all of that's important too. And we talked about reading policy rules, things like that, things that you just inherently know. You need to check those claims to make sure they adhere to those new rules and such. Coding errors, so if you're missing a modifier, if you're undercoding, things like that. An inexperienced biller won't catch that. Somebody who's been doing it for a while will. Insufficient medical necessity language in documentation. That's another thing. If you're looking at the documentation, if you're filing an appeal, you know what needs to be in that note. So that's something an experienced biller knows that somebody new to do it maybe would not pick up. Sometimes payer specific rules. Again, we talked about that they different CPT ICD-10 combos that the payer wants to see. Make sure that that's highlighted on your claim. And those are the things that you need, that you check with payment scrubbing. Besides payment scrubbing, the experienced biller can take care of.
Very well said. And I think from this point on, if you're okay with this, Susan, I think your name could be Susan Accurate Saramelli.
Okay.
But,
I like that. I like that. Yeah.
Just a recap. You talked about how an experienced biller in the right technology are going to catch things like missed or outdated insurance information, termination, a missed modifier or coding issues, insufficient medical necessity. And you have a lot of experience in across industries, including things like behavioral health and mental health and substance abuse and however, what I hear basically is that what we see is that Medicaid heavy organizations like community health centers that deal with a lot of Medicaid heavy patient populations or behavioral health, as your folks deal with, they usually actually have higher denial rates. And they have a lot of issues with things like coordination of benefits or missed or outdated insurance information or lapsed coverage. And a lot of times that's usually where the majority of the denials come from. Whereas specialty groups like your dermatology, your cardiology, your oncology, they deal, like your gastroenterology, they deal a lot with prioritization issues. They deal a lot with missing documentation, insufficient medical necessity. That's what they deal with as well, along with the coverage issues. So depending on which segment of healthcare there can be more common reasons of denials that at the time of claim scrubbing, you have to then make sure you look for and catch. Because if you can catch those 80-90% of denials, now you're doing a really good job in making sure that everything is set up to get paid cheaper, faster, and better, right? So now, Ronald, on your side, you tell us, I mean, where does an agent, an AI agent, actually check during scrubbing? And how is that different from the static rules that a clearinghouse, for example, already runs?
I think you kind of hit the nail on the head. The static word is very important, because what the clearinghouse is going to do, like Susan said, is it's going to check the claim, but it's going to match the claim against a set of rules which is already available, let's say in a spreadsheet. For example, is the NPI present? What is the modifier? What is the CPT code? It is going to check all of these rules and make sure that the claim is kind of clean before it moves out of the door. What it does not tell you is whether that claim is going to get paid or not. And I think in that aspect, AI agent can come in and it can provide more context. Let me give you an example. One of the things that we have been doing with a long-term acute care facility is to understand how we can reduce their denials with particular insurance companies before even the claim leaves out of the door. And the only way we can do that is because we have seen a previous history, or we have tracked the last 6 months of data of what has led to a denial for this long-term acute care facility, particularly with specific CPT code matched against the payer-specific rules. So what an AI agent can do, which is more on the lively real-time environment, is it can essentially see that this particular claim is going to be moving out of the door. Here is the specific CPT code, and here is the payer. But 40% of the times in the last quarter, when we use this claim with this specific CPT code against this payer rule set, it has been denied. So there is a reason for us to reanalyze and double check on things before we submit this claim. I think this is one point where AI agent can come in and it can flag these situations before the claim is left for denial. I'll also add one more point, which has been a topic of discussion recently, which is coordination of benefits mapping, making sure that you are essentially billing the primary insurance of the patient in the right way, which is in reality the primary and not a secondary. And that's one area where AI-enabled insurance verification can interpret the 270, 271 in such a way where it can flag the instances where it can tell you that this patient, you are billing this patient for, let's say, United Healthcare, but it seems like there's a different payer who is the primary and not UHC. And as a healthcare provider, as a healthcare practice, you are informed, or rather you are well informed about that way in advance. So all I'm trying to tell you is if an AI agent comes in, it can be much more proactive in nature when it comes to denial prevention, instead of being reactive when it comes to recouping the claims after the denials has already happened.
Very well said, Ron. I'm going to go back to the question, but to do some math, think about if you're a healthcare provider that has about $100 million in revenue every year. Well, 12% denial rate means you're getting about $12 million out the door, and about $3 to $5 million is actually front-end denials, things you could have caught with ineligibility, prioritization, registration, things that we've all touched upon. So that's $3 to $5 million out the door. And out of that, about half of it comes from coordination of benefit errors, of just billing the wrong payer. Like that is a situation that is affecting so much within Medicaid, Medicare Advantage, Medicare. If you're dealing with that, or if your patients often have secondary insurance, that's going to be a common cause of denials, no matter what segment of healthcare you're in. So now let's go a little more on where more technology can help. So for example, things like claim status checks. So status checking used to mean like someone logging into portals every morning. The question is, how does an agent handle that? How often is it actually checking, and how does it know which payers to chase harder than others?
Correct. Great question. I think gone are those days where you have to log into a dozen portal and, first of all, take the patient's information, subscriber, date of service, member ID to run a claim status check on the portals and see what the claim status looks like. that is still prevailing in many healthcare practices, mechanism of RCM. But I think right now, one of the things that we have seen is, why don't you use automation or AI to go behind the scene with direct integration to the clearinghouses like Availity? And why don't you depend on these AI agents to run the claim status checks for you? The thing that we have to keep in mind is the proper use of AI is important. You cannot misuse AI, or you cannot wrongly instruct AI. If you are instructing the AI within some checkpoints or within the boundaries, and you are controlling the AI's entire mechanism, there is hardly a chance that AI can do something which is of grave mistake. We're talking about claim status checks. One thing is claim status checks, where I think it's already available also in some of the EMR these days, which tells you like in which particular state this claim is currently, whether it's denied or whether it's paid. But the thing that you have to keep in mind is, you do not unnecessarily need to run the claim status check every single day. You first need to see which payer is against that claim and what's the typical rhythm and behavior of that payer. For example, some payers might not give you a result in 14 days. So it's needless for an AI agent to take that particular claim information and run a status check on day 2 or day 3. It's not going to give you any information. So that's often an information which is not passed along in the world of revenue cycle very well, I think. But the second thing which is very important is, an AI agent can do multiple things these days. Why will you just restrict the AI agent to do only claim status checks? Why don't you give it the permission to take some decision making based on what the claim status is? For an example, we are working with the second largest mental health care provider from Illinois. Obviously, BCPS of Illinois being their biggest insurer, and obviously they have good contracts with them. But some of the things that we have observed with this particular group is that a lot of the claims that they get denied is because of one status, which is no authorization. And that's not like a one-off thing. We have seen this thing with other practices as well. But in many situations, when the insurance company is telling you no authorization, you did not take their authorization before you provided the service to this patient, you could very well see that the providers did follow the rule according to the book. They did get the authorization in the first place. They did file the authorization, but somehow the insurance companies are trying to claim that they did not take the authorization. So what have we done with Agentic AI in this particular instance is simply going inside the encounter level data within the patient's chart, finding the billing information, seeing whether it was authorized in the right time, who was the insurance company against which it got authorized, and whether we have a progress note available that shows that this patient did get the treatment in that particular specific date where the authorization was already available. Now, our AI is taking all of these data points. It is taking the progress note. It is filing an appeal against the clearinghouse and telling the insurance to reconsider this request by providing the progress note and the reference of the proof that it was already authorized at this particular date. Now, what happens is, it's kind of like a staggering stat I was reading, Susan and Gabriel, this morning, which is 65% of the denials are never reworked on. But think about this particular denial. If you are able to rework on this denial, you're essentially giving a proof to the insurance company that you did get the authorization before you provided the service. That is going to be an overturn of the denial. So I think a lot of the money that is left on the table can be recouped if we're able to use the AI with proper instructions and in the right way.
Ronald, well said. I love the statistics, as you know I do. And a few other stats, because you mentioned a really good one with 65% of denials are never reworked, is that payers are leveraging AI at 2 times the rate of healthcare providers. So they have an army of agents fighting, and providers have half of the army and are expecting to win. And the army is simply very rules-based, because most of this payers are denying based on rules that exist. They're not incorrectly denying. If they are incorrectly denying, you can, to your point, appeal and win that case. The other stat is this. I mean, made me think of how we did a webinar several months ago with one of our large nonprofit mental health providers, and they had a 4 million drop in AR from automating the things you were mentioning around coordination of benefits, verification of insurance. And that eased things up a lot on their back end AR team to focus on what really mattered, things that they actually had to focus on, not things that could have been caught by technology in the beginning or putting all the guarantors in the right sequence. And they said that actually they calculated it, and it took $50 to rework each denial. So think about the amount of denials they were receiving, because they actually had an 87% drop in their eligibility denials. The amount of denials they were receiving and how much money it was taking just to rework the denials and things their resources couldn't do. And then they actually freed up 7 folks to focus way more on the AR and patient-facing things and things that needed to be done that were not being done. So with that being said, Susan, I'm gonna go to you, because that company, funny enough, they automated on the front end, then they automated payment posting. Let's talk about that a little bit. So Susan, on payment posting, I mean, why does payment posting matter so much? Like, what goes wrong downstream when it's sloppy or done in an inaccurate, incorrect way?
Accuracy. Accuracy matters in payment posting because of a lot of issues. First, for one thing, your accounts receivable will never be accurate if you're not posting the proper payment to the proper account. You will have either an inflated or deflated AR based on how the payment was posted. Your cash flow is skewed also because you may need to balance bill or bill the patient, and you don't know that because the payment has been posted improperly. Also, you have an unrealistic view of your denials if you are posting things inaccurately. You want to make sure everything is posted properly so you know exactly what's going on with your accounts receivable. And also the patients can see this too, because they keep track of their accounts. They see if they're paying, the insurance is paying, or they get EOBs from their insurance company that says the payment has been made, but the doctor's office isn't showing that. So then there is a little disconnect there, and you lose a little bit of trust that you know what you were doing. So when it's sloppy, you see payments posting delayed, piling up, not posted into the system. When you're doing it automatically, you're just hitting a couple buttons, and the system does the work. And then there is human involvement there too. You're checking, it'll flag some things for you to check, but it happens faster, it happens more accurately, and then you're able to move on to the next one. And then you're not worried about applied payments. A problem that happens if you put the wrong payment on the wrong account, say the patient is Jane Jones and she was seen March 1st and April 1st, and you get a payment for March 1st and you apply it to April 1st. Now what happens is March 1st is paid, but you're wasting time sending staff looking for that payment, calling the insurance company, using the automated tools, things like that, when that money is sitting in your bank and you think the money's in the bank for April 1st, but that one's out there and you're not doing anything about that. So those are some reasons that inaccuracy can mess things up. And it also gives you a distorted view of what your accurate accounts receivable is. That's one thing in a revenue cycle. You always want to have a good idea of what your accounts receivable is. Everything starts from there.
Excellent, Susan. Very well said. Thank you very much for sharing. And it made me think of what you said, made me think a lot about like the dental industry, because the dental industry is a little bit different from other pieces of healthcare because they deal with insurance accounts receivable and patients accounts receivable, because a lot of patients do self-pay or deal with dental insurance that usually covers a little bit less than in hospital settings or in professional billing settings. So, I mean, let's go a little bit deeper into that, Ronald. So, I mean, Susan said posting basically demands near perfect accuracy and human review. You tell us a little more, Ronald. Where does the agent actually add value in posting? What is it doing on EOBs versus ERAs before a specialist ever looks at it? And how does it handle the messy ones?
Yeah, absolutely. I think talking about ERAs, the ERAs are a little bit more streamlined and easy to work on. I think that's one of the things that we have often heard from our clients as well. Like, in fact, some of the EMRs are having a feature to auto post the ERAs these days, where the EMR has got the capability to match the claim line items against the payer specific rules. But I think to Susan's point, AR is almost like the backbone of the healthcare group and not just revenue cycle, because the AR decides on the cash flow itself. In terms of payment posting, I think the opportunity for agentic AI is still on the vertical of paper EOBs or payer-specific PDFs, however you call it. And there's still so many payers which lives in the Stone Age where you need to go inside the payer portals, download the EOBs, and then start working on it. It's not like it's going to directly come into your EMR, even if it's an EOB. You still need to fetch it from a portal. I think that's where automation and other technologies can step in a little bit, in a sense where at this point, the technology of optical character recognition, OCR, or data parsing is available, which can read an EOB, which can find the payer-specific information, which can find the denial reason codes, which can see the contractual obligation, the patient's responsibility, all of these data points. And instead of someone sitting in the desk at 4 p.m. in the evening and manually keying in the information from an EOB to the system, there is already programs which are available in the form of automation, which can read the data from these EOBs and then key it on into the EMR. So I think that's a big win for any healthcare practice if they're still relying on having maybe a set of human brains to read those EOBs. But there's definitely an area where we still need the specialists in the medical billing to take some decisions. Let me tell you this in this particular way. If we are able to balance the payments and post the payments with automation and agentic AI, that's fantastic. But there would be several instances where there is a recoupment that you need to do, or there is an unmatched payment. And we need a specialist to step in, because you need a specialist on your back end who can handle those critical scenarios with judgment. So it's a question of how you can balance a process with, let's say, 50% AI and 50% humans. But do not let that particular specialist work on things which are unnecessary. Let that human work on things which are exceptions, which are areas where clinical decision-making or human judgment is required. Let automation and AI take care of reading an EOB and posting it if it's a clean posting process.
Well said, Ronald, especially because you kind of hit on the point. Basically, what we've seen is that statistically, payers underpay 7 to 11% of all claims, and it's almost never caught unless you basically check every single line of each payment against your contract. That's what's possible with expertise and technology. Susan, if you don't mind, let's bring everything together. We talked about a lot of topics. I mean, the revenue cycle is not an easy thing to talk about in 30 to 45 minutes. But if you're bringing it all together, Susan, where does a typical healthcare provider leak the most money? And in your opinion, which fix moves the needle the fastest?
Okay. I think the biggest leaks are through denials and appeals. Appeals are either not filed or not filed properly. The correct information is not sent in, or not pursued once the appeal is sent. You have to make sure that you stay at that insurance company, because if you are contractually right, then you deserve that money, and you need to work through all of the channels that you're afforded to make sure that that happens. So there are different kinds of appeals you'd file: medical necessity disputes, prior authorization, if you've gotten prior authorization and they're denying it that way, eligibility errors, things like that. Then you have to also avoid the other thing that you leak money in is you're not following all of the rules that the payer sets up. If they require a prior authorization, make sure you get it. Make sure you include that on the claim form. Make sure you adhere to timely filing And that those windows get shorter. They used to be 365 days. Now you're seeing 90 days timely filing. I've seen some insurance companies with 30 days. You've got to get those claims out. Another timely filing one that you're unaware of is if the insurance company denies a claim, even if they deny it erroneously, you only have a certain amount of time to appeal that, or else you're out of luck. So that's why you lose a lot of money if you're not aware of those rules and the avenues you can take to correct them. Denials are instant losses until you do the due diligence and figure out why they're denied and what you can do to get that claim processed. So you should take a look at your revenue cycle. We talked about all of the different parts of it. Make sure you don't have any holes there. Make sure all of it is moving smoothly. Automate where you can. The automation is key. It helps all over the place. You know what we talked about, the computers, they are more accurate. Well, we talked about the accuracy word, but they don't make the errors that humans make. But make sure you have a good staff of humans that know what's going on with these claims, know how to submit the claim, and know how to audit them. So I think both of them together, the human being and the automation side, make for a good revenue cycle.
Awesome. That's on point. Basically, you got to get your denials and appeals process on point and correct to make sure you're recovering as much revenue as possible for your client. Just getting them paid. That's the goal of this, right?
Right.
So, Rano, cap us off if you don't mind. I guess from your perspective, based on everything Susan mentioned, I mean, from the automation side, Rano, if you had to name the single place where agents change the economics of revenue cycle the most, where is it? Why hasn't the industry done it already? Tell us a little more.
Yeah, absolutely. I would definitely answer that. But one thing Susan picked up was essentially a very good point, which is for you to appeal on those denials, you only have a specific time frame and a window within which you have to make that appeal process. Unless you do it, you are not going to get the denial overturned any which ways. So I think one of the areas where Agentic AI can definitely help is compressing the timelines. You know, what you used to take hours before, perhaps now it could be done in minutes. And that's where automation and AI can come in, because the time period for submitting an appeal is not going to be everlasting. So I really like that point from Susan. I think to your question, Gabe, one of the particular thing if we have to focus on with humans, with AI, is essentially moving the work from back end to front end as much as we can. It's not always possible, but if we can prevent the denial before the claim moves out of the door, then it's a big win for that particular healthcare practice. The economics on the back end is already brutal. You touched on it, that the denial rate on an industry standard is right now sitting on top of 12%. And I was seeing that it used to be 10.2% on 2024. So it's almost like a 2% increase in 2 years. In fact, we also know another stat which is pretty staggering, which is on average, if you need to work on a denied claim, you are perhaps looking at an expense of something between $25 to $181 per denied claim to be worked upon. So, the maths tells us that a denial prevention is a better step than, being reactively working on a denial. Let me put it that way. The question that comes along is, why haven't we done it yet? I think there are two reasons why, because of which we haven't done a lot of these things in terms of improvement. The first thing I would say is that the data was too much fragmented. We still see with different health systems that they're using multiple systems across the board. There's an EMR for which they keep the patient's history, patient's medical records, and all of that stuff. There's another system where they keep the payer contracts, and then there's another system where you have the credentialing information. Interoperability across healthcare was a very big challenge. We have seen over and over again two systems were not having the capability to talk to each other. I think right now that problem has been solved to some extent of the last couple of years. The second point is the technology was not ready. Even if we were having this conversation 10 years back, I do not think we would be using the terms like large language models because LLMs wasn't invented at that point. Broadly, we could have used the term AI, but AI simply meant perhaps automation at that point. I think right now, with the advent of LLMs, it's almost moving at the speed of light. A lot of things is possible, which was not possible back then. I would end up by saying one more stat. I think 82% of providers says that denial detection is a top priority for them, but only 14% of health practices have started using AI. So I think the gap is the total market opportunity for kind of AI clients out there.
I mean, I can't thank you guys enough, Susan and Rano. I think what's happening too is that revenue cycle teams are just surviving. Like when you're being hit by this denial, that denial, and just all of this work, it is difficult to focus on how to fix everything at once. And there's so many problems. That's where it does come into play when you have specialists that can focus specifically on one problem at a time to solve each one. For example, like coordination of benefits. That's a very specific problem that you fix that. It relieves a lot of work for you on the front end and the back end. So I think that's the point, that instead of surviving, keeping the lights on, a lot of these rev cycle staff, they need a little bit of help, a little bit of support, because honestly, healthcare providers cannot hire fast enough. This is one of the fastest large growing industries in the United States. This is one of the industries that no matter what we do, AI is not going to make it that it's only going to help the industry, and it's more needed, right? A lot of industries are decreasing and healthcare is increasing because there's more and more of a need in the United States healthcare system. So I think just recapping everything, we talked all the way across rev cycle, all the way from ingesting data to scrubbing data to submitting the claim, tracking the status of the claim, posting payments, AR follow-up, and even appeals and denials, and where technology fits in. And again, a lot of that technology fits in mostly in the submitting, the tracking the status, the payment posting, and appeal denials. But when it comes to scrubbing and AR follow-up, that's a piece specifically that you really need a lot of experienced billers and subject matter expertise to do it well. So thank you again, Susan and Rano. If anyone wants to see the recording, it's coming up shortly after this, and have a wonderful day.